I'd like to thank you very much for inviting me to talk today. I'm Dr. Kevin Kavanagh, Board Chairman of HealthWatch USA, and would like to discuss with you today COVID-19 Lessons Learned, a Global Perspective. On June 15, 2021, HealthWatch USA and the Massachusetts Nurses Association held a webinar which brought together infectious disease experts from around the world with two major goals. One was to share experiences and strategies to mitigate the SARS-CoV-2 pandemic, and the other to obtain a worldwide perspective to combat misinformation, which is often predicated on local or regional politics and the mistrust of government. All of the presentations which I reference can be found at healthconference.org and are part of a continuing educational program put on by Southern Kentucky AHEC. And the PDFs for the slides that I have here today can also be found at healthconference.org towards the top of the website. Now, with the emergence of the Delta variant, much of the world is entering into its fourth or even fifth wave of COVID-19. Currently, there are 200 million cases and over 4 million deaths. Overall, nations have had a number of different strategies and strategic responses to confront this pandemic. An article published by Baker et al. Categorized these responses into 5 different types. They include an exclusion strategy. Some Pacific islands adopted this. They essentially walled off their island from the rest of the world. An elimination strategy. This was in Singapore and Australia, where there was maximum action to exclude disease and eliminate community transmission. A suppression strategy. This was seen in the United Kingdom and European Union, where stepwise targeted measures were taken to lower case numbers and outbreaks until a treatment or vaccine became available. A mitigation strategy. This was seen in the United States, Brazil, and India. And in this strategy, many of these leaders were hoping for herd immunity without a vaccine to flatten the peak until a vaccine or treatment became available. And finally, I hope that no country adopted a no substantive strategy, in other words, to do nothing, hoping the virus will miraculously go away. I would like to concentrate on 3 countries, India, Brazil, and the United States. These countries arguably had some of the worst response to the pandemic, which resulted in both large case numbers and deaths per capita. All 3 countries appeared to have abundant misinformation that was spread by social media and by their leaders, which led to large rallies and religious events. A large segment of the population believed herd immunity without vaccines was possible. These countries were unable to formulate an effective uniform national strategy or to resolve disagreements between the scientific communities and policymakers. And all of the countries had an underdeveloped or a non-coordinated public health system. Now, misinformation has been one of the greatest impediments to controlling the pandemic, and it comes from 2 major sources. One is social media, and the other is news outlets. Misinformation can also come from governments and elected leaders. False information was spreading widely on the internet. A study by Carnegie Mellon University found that nearly half of the accounts tweeting about the coronavirus were likely bots, and these bots seemed to follow the playbooks of the propaganda machines of Russian and Chinese governments. This was confirmed by a Reuters report which demonstrated a European Union document detailing how a Russian disinformation campaign was pushing online fake news. The fake news was in multiple languages, making it harder for the EU to communicate its pandemic response. And recently, the United States government has identified 3 online websites directed by Russian intelligence which spread disinformation regarding the Pfizer and Moderna vaccines. In addition, they also spread disinformation regarding international organizations, military conflicts, protests, and other divisive issues. In Brazil, the misinformation even resulted in public health officials who were trying to deliver vaccines to indigenous populations to be met with bows and arrows. In India, where the country ran out of oxygen and hospital beds, the population started to frantically hunt for ineffective medicines and untested homeopathic treatments. The Russian misinformation campaign against vaccines actually started before the COVID-19 pandemic, and news reports documenting this disinformation activity was found in 2019 and 2018. Unfortunately, this activity has largely been successful, with 1 in 5 Americans now believing the vaccine contains microchips, despite the fact that the Pfizer mRNA vaccine is reconstituted in the clinic. It is injected with a very small needle, and multi-dose vials are used to draw up the vaccine. This makes absolutely no sense. So common misinformation talking points include that the vaccines do not work. Again, this is entirely false. The mRNA vaccines against the Alpha variant were preventing hospitalizations and deaths. 99% of those hospitalized or died in May and June were the unvaccinated. So the vaccines work, and they have effectiveness in preventing deaths and hospitalizations with even the Delta variant. That there's microchips in vaccines, again, absolutely false. Besides, if they wanted to track you, they'd just use your cell phone. They don't have to put microchips into you. Vaccines have high death rates? Absolutely not. There have been extraordinarily few deaths attributable to these vaccines, and there have been billions of doses administered worldwide. And this compares to the mass graves that we're starting to see in many of the countries because of COVID-19. Vaccines change your DNA? Absolutely false. mRNA vaccines are injected into the cytoplasm of the cells. The mRNA does not get into the nucleus. It does not, absolutely does not change the DNA within the nucleus. And the mRNA at that point in the cytoplasm just produces a protein, the spike protein. And then it is very unstable, so it rapidly goes away. Vaccines decrease fertility. Again, completely false. Vaccines do not decrease fertility, but in fact, there is some concern that COVID-19 may decrease fertility in males. There's been several papers on this, and this is because the testes have a very high ACE2 receptor concentration, and there have been documentation of both abnormal and decreased sperm counts. Vaccines have not been adequately tested. Again, absolutely false. We have had now over a year of data on some of the initial trial subjects. Many people are tracked, both in the Department of Defense, the VA system, and using VSafe, which is a CDC initiative. And people now have been tracked well over 6 to 9 months. Abundant quality information is present, and boy, these vaccines are some of the safest, if not the safest, that have ever been produced. Vaccines are FDA authorized but not approved. Now, this is true. However, they're not experimental anymore. We've had hundreds of millions of doses in patients in the United States alone. Ample quality data. More data is now sitting on the FDA's desk than ever before, and we expect approval within weeks. Vaccine misinformation is also a large problem in Europe, especially in France, where only 56% of the population had confidence in the vaccine. However, this is not true for every country. In Spain and Italy, these were exceptions where 78 to 81% of the population had confidence in the vaccine, and even more were willing to take it. In third world countries, the vaccine is in short supply. In Peru, there was great demand for the vaccine, whose doses were delivered on foot, across rope bridges, even by donkeys, to reach the homes and to vaccinate people in homes. Unfortunately, in the United States, in-home vaccination programs have become a great controversy. But in Peru, the Peruvians view this as one of the great successes of their public health programs. This slide shows 2 social media posts containing misinformation. One of the posts asserts that COVID-19 is no more dangerous than the seasonal flu. The other posting asserts that the flu cases are being misdiagnosed as COVID-19. And unfortunately, this misinformation is already spreading widely over the internet. Underreporting is another problem, and this paints a false picture of COVID-19's true impact, making it harder to mobilize resources and easier for many to deny the severity of the pandemic. During the Ebola epidemic of 2014, the government of New Guinea, a country with very limited healthcare resources and testing capabilities, initially insisted that only laboratory-confirmed cases be counted. This led to a drop in reported cases and a false sense of security, which delayed the mobilization of resources and fueled the spread of the virus. Early in the COVID-19 pandemic, there was also abundant misinformation regarding how COVID death rates were less than the Spanish flu. This information was false, since the comparisons were made using different metrics. One counted actual deaths being reported, the other counted excess death data. Now, the commentator of the post in the previous slide was from Russia and lived in the Dominican Republic. I confronted him on this, and he actually admitted that he was from Russia and that he lived in the Dominican Republic and became a naturalized citizen there. We actually had a fairly cordial correspondence. After that, he backed off and no longer left postings that were disinformation on my websites. Governments can also promote disinformation and misinformation. The Harvard Kennedy School concluded that in Brazil, risks of COVID-19 were mitigated by strong rhetoric from the highest levels of the Brazilian government. In Peru, a country with very limited healthcare resources, and this is similar to New Guinea, required that only patients with a COVID test be counted. In Peru, this resulted in a threefold underestimation of cases. Recently, the government readjusted their data, and Peru now has the highest deaths per capita than any other nation in the world. And we should note that Peru has currently the Lambda variant, which many are worried will be causing another wave in the United States. In India, the official count is now over 430,000 deaths, but it may actually be higher. In many instances, only confirmed cases with a positive COVID test are counted, but many patients cannot even obtain a test. And those dying of comorbidities may also not be counted, lowering true estimates by another 50 to 80%. And for all too many, they are not even able to access the healthcare system. A new estimate found the number of deaths in India to be 10 times higher, with nearly 5 million fatalities. In the United States, there have been well over 600,000 reported deaths. New estimates using excess death data has placed the death toll at well over 900,000. The reason for this discrepancy can probably be explained by research from the Veterans Health Administration. They found that up to 8 extra deaths per 1,000 COVID-19 cases occurred between 30 to 180 days after diagnosis. So this is almost 1% of the COVID-19 cases. Now, these late deaths are not always captured and are due to a plethora of effects caused by COVID-19, including chronic blood clots, strokes, diabetes, and breathing difficulties, along with heart, liver, and kidney damage. The argument that COVID-19 deaths are actually seasonal flu deaths is misinformation. And the best example to refute this can be found in Singapore. Singapore enacted a stringent elimination strategy, and all respiratory viruses, including the seasonal flu and SARS-CoV-2, disappeared, as did enteroviruses. After these strategies were lifted, many of the viruses returned, while the seasonal flu remained at almost undetectable levels through 2020. Now, this slide shows the disappearance of the seasonal flu and near complete disappearance of all respiratory viruses with enactment of stringent mitigation strategies in Singapore. You can see right here with the red line, which is the flu, with stringent mitigation strategies, this and other viruses disappeared in this trough. However, when the strategies were lifted, and as shown by the dashed blue line, rhinoviruses and enteroviruses reappeared. And later in the year, as shown by the solid green line, adenoviruses started to reemerge, but seasonal flu remained at an almost undetectable level. Despite mitigation measures, there have been a few outbreaks of COVID-19, even though seasonal flu remains almost undetectable. So again, mitigation measures work, but COVID-19 tends to be extraordinarily infectious and can overcome these protective measures. Herd immunity. Herd immunity happens when enough of the community becomes immune that an infectious pathogen stops spreading. And this is something that you'll hear a lot about, but it is very hard to accomplish. And in reality, very few infectious diseases have been stopped with herd immunity. Now, by the spring of 2020, some were advocating for herd immunity as a strategy to stop the virus in poor countries. This was again advocated in the fall of 2020, when there was great optimism and many declared the pandemic over. However, the world was then hit with a large wave over the winter holidays. And currently, we are now into our fifth wave of this virus. And this should tell you we are not dealing with a Spanish flu-like virus. 5 waves is almost unheard of with an infectious agent. We are dealing with a highly infectious, mutating pathogen. Although most states in the United States are into their 4th wave, some of the states, such as Florida, are into their 5th wave. In India, some declared herd immunity to be achieved in February of 2021, as shown by the vertical green line. However, India then had to endure an even bigger wave caused by the Delta variant. In Delhi, herd immunity was thought to have been reached in 2021, with a high proportion of their population having antibodies to SARS-CoV-2. But the city was then crushed by the Delta variant in the spring of that year. So again, these variants are causing many times reinfections and repeated waves in the countries. In Brazil, herd immunity was felt to be achieved in the city of Manaus, where 2/3 of the population had antibodies to the virus. Others at that time may also have been immune with no detectable antibodies, but still having memory B cells. But this city was again hit by even a larger surge, caused by the Gamma variant. In the United States, many felt herd immunity was achieved in the states of Arizona, Texas, Florida in September of 2020. This is shown in the vertical green line. But then a large winter spike occurred with the Alpha variant. Now I should note that the summer surge was caused by the D614G variant. So again, different waves caused by different variants. Finally, in the summer, on July 9th, 2021, herd immunity was felt to have been reached by some of our federal leaders, estimating that 80% to 85% of the population was immune. Soon after, however, we started to see our spike from the Delta variant, and we expect this spike to be larger than the one that was obtained over the winter holidays, but hopefully because it is so infectious, it will be short-lived. The Delta variant is highly infectious, over 2 times that of the wild-type or original virus. The wild-type virus has an R0 of 4, being 3 times as infectious as the seasonal flu. Now let me explain. An R0 of 4 means for every person infected with the virus, on average, they will spread it to 4 other individuals. Thus, a very conservative estimate is that the R0 of the Delta variant is greater than 6. And with an R0 of 6, it will take greater than 83% of the population to be immune and reach herd immunity. And it may actually be much higher than this. The United Kingdom Scientific Advisory Group for Emergency felt a possible pandemic scenario was for SARS-CoV-2 to jump to another animal host. The virus could then mutate and evolve on a different trajectory, only to reinfect mankind at a later time as a substantially different virus. And there is abundant evidence that there are other animal reservoirs for SARS-CoV-2 to enable it to reinfect our population. This includes cats and dogs becoming sick with the virus, along with other large animals. Cats and large cats, such as leopards and tigers, seem to be more susceptible than dogs. Gorillas and primates are also very susceptible. However, it is possible for the coronavirus to jump to a wide range of other species, and many zoos have started to immunize their animal populations. A recent report from the United States Department of Agriculture has found SARS-CoV-2 to be residing in white-tailed deer and appears to have spread to the deer population in at least 4 states. The deer can transmit the virus to other species. They have substantial viral spreading and are abundant near urban areas. Needless to say, this is very problematic. Another frequent advisement, which is not accurate, is 6 feet away and you're safe. This narrative assumes that the virus is spread by droplets and droplet precautions will stop the spread. But a major and possibly most important mechanism of spread of SARS-CoV-2 is by aerosolization. SARS-CoV-2 is airborne. Outdoor aerosols dissipate rapidly, but within 6 feet, you are not safe. Greater than 6 feet may have some safety. So large droplets, even outdoors, can still spread within 6 feet. Now indoors, especially in settings with poor ventilation, 60 feet away is as unsafe as within 6 feet. This is because SARS-CoV-2 is airborne. It has been known early on that SARS-CoV-2 is aerosolized. Early research found an average R0 of 5.2 for SARS-CoV-2, much greater than the average seasonal flu R0 of 1.3. Reports of spread of the coronavirus in choirs, in hospitals, in restaurants where social distancing took place demonstrated, in my view, conclusively that SARS-CoV-2 was airborne. And there was massive and fast spread of the virus around the world, much faster than what would be expected from just droplet or surface spread. A letter on July 6, 2020, which was published in Clinical Infectious Disease from hundreds of scientists, encouraged public health organizations, including the WHO, to recognize that SARS-CoV-2 was aerosolized. Finally, on May 6, 2021, the CDC recognized that airborne transmission was a major mode of SARS-CoV-2 spread. But steps for addressing aerosolization were largely not taken. Well, they just weren't taken the entire year previously. And it was very frustrating for me that a week later, on May the 14th, the CDC then revised their mask mandate, stating vaccinated individuals no longer needed to wear masks. The CDC emphasized that this policy reversal was solely based on science. However, the relaxation of the mask mandates was very, I think, ill-advised. It was enacted despite not being able to identify who is and who is not vaccinated, and it resulted in almost no one wearing masks, and the intent on trying to have people become vaccinated by providing them an incentive did not happen. Now, with the Delta variant, we really have to change the way we act. This is a game changer. The Delta variant is producing 1,000 times more virons or viral particles than the wild type or the original virus. A N95 mask or medical grade mask is needed. Goggles will also help, but above all, avoid indoor, poorly ventilated settings. A common misinformation argument is that masks will not filter the virus. And this misinformation talking point argues that N95 masks filter particles equal to or greater than 5 microns, and a viron is less than 1 micron in size. However, there is also an electrostatic capturing of even smaller particles by N95 masks. And most importantly, the droplets spread by talking, screaming, and singing are between 10 to 100 microns. Thus, solitary dry virons are not the major spread threat. It is the virons which are encased in mucus and water, and these are easily captured by a mask. The National Academy of Sciences reported new evidence which found particles larger than 5 microns and smaller than 100 microns can be produced by speech and can aerosolize. Before 2020, it was felt that particles had to be less than 5 microns to aerosolize. We now know that these smaller droplets can aerosolize. They can spread farther than 6 feet. They can float in the air for an extended period of time and can survive for up to 3 hours. So these aerosolized particles are felt to be the major drivers of the SARS-CoV-2 pandemic spread, which is why masks work. So please encourage everyone to wear them. Now, the size of the viral particles which are spread by singing and speaking was measured using laser light scattering techniques. And again, the particles were found to be between 20 to 500 microns. Particles above 100 microns are the larger particles, which will fall within 6 feet, but those less than 100 microns can aerosolize, they can spread much further, and N95 masks are best for filtering these particles. In October of 2020, the National Academy of Sciences produced a report which describes the propensity of SARS-CoV-2 to aerosolize and the importance of particle size. I would definitely download this report and have it as one of the references in your armamentarium. It is very comprehensive and drives home the point that we need to worry about particles between 10 to 100 microns. These are the ones that spread with SARS-CoV-2, and N95 masks are effective in preventing this spread. Now, dosage matters, and this is something that is extremely important. It's not black and white. You're not either exposed or not exposed. It is a numbers game. The more virons you're exposed to, the more likely you are to be infected, and the more likely the infection is to be severe. This is for both vaccinated and unvaccinated individuals. It is highly unlikely that you will be infected if you're just exposed to one viron. The chances of that viron randomly finding a receptor are not that great. So again, wear masks. It is a numbers game. A New York Times poll released on May 13, 2021 of epidemiologists in the United States found that 80% thought Americans would need to wear masks in public indoor places for at least another year. Another misinformation talking point is we do not have to do anything different with the variants. This is absolutely false. If you remember, the second and third surges in our country were caused by new variants. The Delta variant is the virus we're currently dealing with. This is the third iteration of SARS-CoV-2, which has caused widespread surges in our country. So we were first originally infected with the wild type or Wuhan variant back in February and March of 2020. During the summer and August, we had a surge caused by the D614G variant, which was 1/3 more infectious than the wild-type variant. Then over the winter, we had a surge caused by the Alpha variant, which was 70% more infectious than the wild-type variant. And currently, we are entering into a surge caused by the double mutation Indian variant or Delta variant. This is over 2 times, some state 2.5 times more infectious than the wild-type variant. And there is still the Lambda variant, which arose in Peru, that has the potential to be even more resistant to our immunity than the Delta variant. Associate Professor Dr. Sato from the University of Tokyo told Reuters, Lambda can be a potential threat to human society. And there is also the Kappa variant, which is the Delta variant plus another strategic mutation. All of these variants are waiting in the wings and may cause new surges in the future. This picture shows an award ceremony which was held for frontline workers in July of 2020. All were said to have been wearing a badge that they were vaccinated. However, none were wearing masks or social distancing. This is very problematic. A report from the Israel Health Ministry found that the Pfizer-BioNTech vaccines overall had only a 39% efficacy in preventing infections and a 41% efficacy in preventing symptoms with the Delta strain. However, they still were highly effective in preventing hospitalizations, and they even had a higher effectiveness in preventing deaths. This report also showed a marked decrease in effectiveness in preventing infections and symptoms over time with the Delta strain. Effectiveness decreased from 75 to 79% if the second dose was given in April to only 16% if the second dose was received in January. But again, there was still excellent protection for hospitalizations and deaths, with the exception of the subgroup of patients who were over 60 years of age and received the second dose of the vaccine less than 5 months ago. In this group, Israel is hurrying up and giving boosters. They had a substantial amount of deaths recorded in this group, 2%, from reinfections. And unfortunately, in the United States, many of our patients in the nursing homes fall into this category. Now, as an aside, some may say, well, the English data is much better. It shows that the vaccines are crushing the virus. And that's true. But in England, there was a 3-month time period between the first dose and the second dose, and they started vaccinations somewhat later, so that it pushed their final vaccination dose later in 2021. And most of their population is not more than 5 months post-vaccination. The United Kingdom is setting up for boosters starting in September, as is Germany and other countries. We, on the other hand, are still sitting around deciding what to do. A July 19th, 2021 report from the Lexington Health Department found that 23% of all SARS-CoV-2 infections were breakthrough infections. And of course, this was at a time when not all of our cases were from the Delta variant. During that time, the full vaccination rate in Fayette County was approximately 58%, and this equates to a vaccine efficacy rate of approximately 60%, which is similar to the Israeli data, because again, we weren't at that time overrun with Delta, although a lot of infections were Delta, not all. LA County also has reported that more vaccinated individuals are testing positive. LA County, along with other municipalities, recently enacted mask mandates for all. This includes both vaccinated and unvaccinated individuals. Again, vaccinated individuals can get the virus, they can spread the virus, they can get mild, moderately infected, and with that, there's a risk of long COVID. The one carve-out is, if you're over 60, greater than 5 months from last vaccine dose, Israeli data shows that you may be at risk for hospitalizations and even deaths, and those have occurred in 8.6% of the population and 2% of the population, respectively, as reported by the Health Ministry of Israel. Now, the Delta variant has 1,000 times more virions, making it more infectious. And this may also enable it to overrun our immune system. Again, as another aside, when you hear about all these laboratory tests that antibodies are still holding up, they may be 1/3 as efficacious, but they're still working. And that is good news. But the Delta variant is coming into the battle with 1,000 times more soldiers. So again, it may be overrunning our immunity, which is one of the reasons why we're starting to see breakthrough infections in those who are vaccinated and the elderly starting to have their immunity wane at an even faster rate. And we also need to remember that about 2.7%, or 1 in every 37 individuals in the United States, has an immunocompromising condition. This includes patients with an inflammatory condition such as lupus and rheumatoid arthritis, patients on chemotherapy, and patients with transplants. Vaccines may not be as effective in these patients, especially in patients having full organ transplants, so that a booster shot may be needed. Former U.S. Surgeon General Jerome Adams stated the CDC's past policy on removing masks was wrong. It motivated almost no one to get vaccinated and resulted in no one wearing masks. The American Academy of Pediatrics has recently stated all students and teachers, both vaccinated and unvaccinated, should wear masks. The WHO also urges vaccinated individuals to wear masks, especially in areas with community spread. In Israel, when the test positivity rate rose above 1.5%, new strategies were being planned, such as vaccine passports. In the United States, we all need to start wearing masks regardless of where we live. And this is something that's really frustrated me, is that when you look at our healthcare leaders, they say, well, we're going to do this in areas of high community spread. Well, what's high community spread? In the United States, well, apparently in Kentucky, above 10% positivity rate isn't enough to mandate masks. But in other nations, that positivity rate gets above 1%, alarm bells go off. So when the WHO says wear masks, we should have been doing this long ago. And it is very, very frustrating. If you look at Singapore, you look at Australia, when they lock down and have an outbreak, they're talking about 2 patients being positive in a city. In our country, we are really very tolerant of this virus, and I think that we may be doing ourselves some long-term damage and a severe disservice. Now, again, we need to remember that dosage matters. It is a numbers game. So if you're vaccinated and you wear a mask, it will reduce the viruses that you are exposed to in your viral dosage, hopefully making infections more milder. Hopefully you won't get an infection, but if you do, it will become milder. Now, another misinformation talking point is that, well, schools can open. We don't have to do any strategies. Children are safe. And therefore, we don't need to do much. And this is, again, absolutely false. A study last year using the wild-type virus found that students and children can spread the virus to others. So this includes their caregivers, it includes teachers. An October 2020 study out of Korea found that students age 1 to 9 spread the virus half as frequently as adults. And those 10 to 19 spread it more than adults. And it needs to be remembered that the Delta variant is over 2 times as infectious as the wild-type virus. So if your child spread last year's wild-type virus half as much, but this year's virus is twice as infectious, you're really no better off than an adult was last year with spreading the virus. So this virus, the Delta, really needs to be taken seriously. And as we'll be talking about later, the Delta variant has a propensity of infecting children and also causing severe disease in children. Dr. Sebastian Hohl presented data at our conference which demonstrated that during the second wave in Germany, the age of those who developed COVID-19 shifted to younger individuals, including children. As shown in this diagram, peak infections are in red, and there is a definite shift to the younger age with the second wave in Germany. And this is the circle of the red data on the diagram on the right side. Now, this wave in Germany was caused by the UK or the Alpha variant. This variant also was reported to have a propensity to infect children. Now, the Delta variant, that's the variant we're dealing with this summer, is 70% more infectious than the Alpha variant. The Delta variant also is reported to have an increased propensity to infect children, and there have been admissions to hospitals and ICUs of children which are on the rise. This has been reported in Florida, Oklahoma, and Mississippi, and now by a number of other states just in the last few days since I made this slide. When Germany opened schools, there were mask mandates. They tested everyone in schools twice a week. Even with these interventions, there were at least 86 outbreaks documented in daycare centers, nurseries, and schools. So last year when you heard, oh, it's safe to open schools, it doesn't affect kids, Europe is doing that. Well, no one ever stated they were requiring everybody to wear masks and testing everybody twice a week. Schools can be opened safely, or at least safer, but you need to do significant interventions. And unfortunately, we haven't done much to prepare our schools to be open safely through last year, and now we are stuck with a situation that, in my view, is untenable. We really need to get our act together and make sure our children are safe. Another problem is that 24% of the teachers are at high risk for severe COVID-19. We need to open schools safely. Since aerosolization was not initially recognized last year, or at least not by regulatory and advisory agencies, only droplet precautions were undertaken. And these included cloth masks, social distancing, plexiglass desk shields to keep students safe. These were less costly than preparing and trying to prevent aerosol spread, and they could expedite compliance. But as can be seen by this picture, there is a desk shield, but the student is not even wearing a mask. Again, this is for droplet precautions. It will not stop the spread of an aerosolized virus. These desk shields will not work in our school settings, nor will keeping kids just 3 feet away. That is crazy. In fact, it's hard to keep children 3 feet away. They'll kind of stick together like magnets. You got to separate them further. We need to have upgrades to our building ventilation systems, and this includes N95 masks, which are desperately needed. And I feel the school should be providing high-quality masks to all students as they come into school, and they should be at least provided to these students every couple of days. This should be on the onus of the schools to provide. A lot of the poor children do not have access to good masks, and this is going to put them at a significant risk when they come to school. It is imperative that the United States upgrade its buildings and schools. The New York Times reported in 1998 that over half of the city's 1,000 schools were in disrepair, but little has changed. A 2020 United States Government Accountability Report found 54% of U.S. school districts needed to update or replace multiple building systems in their schools. The most common system needing upgrading were heating and ventilation systems, which needed replacement or updates in 41% of schools in the United States. This year, with the emergence of the Delta variant, COVID-19 outbreaks have been reported in summer camps in Texas, Illinois, Florida, Missouri, and Kansas. The outbreak in Illinois involved 80 cases associated with a youth camp. The majority of cases were in teens. There were also examples of vaccine breakthrough infections. The Mississippi Health Department warned of a Delta variant surge and had 7 children in the ICU and 2 were on the ventilator. In Columbia County, New York, 38 children under the age of 12 who attended a New York summer camp were unvaccinated and have tested positive for COVID-19, despite initially testing negative on camp admission. Breakthrough cases are occurring, and we need to remember that even asymptomatic cases can possibly cause long-term heart and lung disease. So breakthrough cases are occurring in vaccinated individuals, and this is very problematic. COVID-19 affects every organ of the body. It can present with GI symptoms and heart symptoms. And, for example, myocarditis, an inflammatory condition of the heart, is often initially asymptomatic. At least 2 CT scan studies have shown changes in the lungs in approximately 50% of asymptomatic patients, and one of these studies evaluated children. Vascular and heart involvement can be the primary manifestation of COVID-19, and it is often initially silent. Mitigation strategies for schools, which should be done. And I would like to actually redo that slide and say that must be done before you open these schools safely. We need to have reduced class sizes, along with hybrid classes, and an option for telelearning, especially for the immunosuppressed. Podding and testing needs to be done twice weekly on all, including vaccinated and unvaccinated individuals. Pool testing can be done, and that will increase efficiency and decrease supply utilization. All need to wear high-quality masks, both vaccinated and unvaccinated individuals, and these should be supplied to the students by the schools. We need to upgrade building ventilation systems, and we need to increase complete air exchanges in our school systems. Schools also need to have good hand hygiene and promote hand hygiene and have frequent cleaning of surfaces. Schools have been given abundant funds, which they need to use to keep our students safe during the COVID-19 pandemic. It is crazy. We are not doing enough. And we will wind up having our children in the ICU, some of which are going to be intubated because of this. This is what's happening in other states. This is what's happened in other countries. To think that it won't happen in Kentucky is nothing more than magical thinking. Now, social disparities. Social disparities have come to the forefront of this pandemic. For example, in Singapore, 300,000 low-income migrant workers had reduced access to health care and were responsible for Singapore's fourth wave, demonstrating the need for universal health care and that we are all living in the same fishbowl. Germany had its first major cluster in a meatpacking plant, which employed very low-paid workers. And over the winter holidays in Germany, a much higher number of cases occurred in Germany's lower-income communities than higher-income communities. In Kenya and Peru, they have inadequate vaccines for their populations. And this is unlike in the United States, where in some areas we have even discarded unused vaccine doses. Dr. Jesus Rodriguez Baño from Spain stated, "It is a global failure. The way the vaccines have been distributed around the world, once again, those of us who live in developed countries are lucky enough to have a much higher probability of receiving a vaccination earlier than those living in low-income countries." So again, as we are wasting and not using our vaccines, other countries are begging for them, and this really is not ethical. Protection of frontline workers is also of utmost importance. Frontline workers should be provided with adequate PPE, including N95 masks, and have access to robust testing infrastructure. We need to increase our COVID-19 testing capability in the workplace and also in schools. Pool testing can be used to increase efficiency and to conserve resources. Pool testing, in case any of you do not know, is where you gather together a number of swabs which you've taken and process them in one test. In other words, you pool together the test. And then, if it's positive, you go back and test them separately. If it's negative, what you do is then say everybody in that group is not infected. So it will conserve resources and it increases efficiency. Now, Germany, for example, mandates testing on all students, teachers, and industrial workers twice a week, and testing is recommended in all workplaces. Many of these countries are using rapid antigen testing. Now, these are relatively accurate, but only during the high period of symptom onset when the viral load is high. But if you test everybody twice a week, you're going to be very likely to pick that up, and identify infected individuals. In Australia, it became apparent that staff in designated quarantine hotels were becoming vectors for SARS-CoV-2, and as a result, their movements were restricted, and they were being tested daily. So that is their current protocol. So again, much more aggressive than what we are doing here in the United States. And I should add that I feel that all frontline workers need to have presumptive workers' compensation and disability because COVID-19 is a work hazard for these individuals, and they are very likely to be exposed in a work setting to this pathogen. Now, healthcare workers, they also need to be protected. Dr. Stephanie Dancer from the United Kingdom stressed the importance of hospital staff in the transmission of COVID-19 to patients. Transmission occurred between staff and patients and from patients on one ward and then to other wards. In Singapore, when there was a COVID-19 outbreak, and again, outbreak in Singapore is a little bit different definition. This is just one or two cases. But when there was an outbreak in Singapore, all hospital staff and patients were tested every other week, and if unvaccinated, weekly. In the United States, we're not adequately tracking infections in healthcare workers or patients. Our metric or way of measurement for hospital-acquired infections will not capture hardly any COVID-19 infections. So if you look at the definition of the metric, in order to be reportable, a patient needs to be in the hospital at the time of the infection. That would be 14 days. But most patients are discharged by 4.6 days. That's the average hospital stay. And they need to be symptomatic. If the patient becomes asymptomatic, again, it doesn't require reporting. And so this is not going to capture hardly anybody. And that's one of the problems. We're not even measuring cases, so we can't have the data and the numbers to find out what strategies we should be using to prevent spread. Now, almost all countries have enacted travel restrictions. Singapore and Australia have strict travel bans, quarantining all that enter the country at the port of entry for 14 days. In Thailand, quarantine period is 21 days. And when I say this, this usually elicits a flurry of people saying, well, what about the border? What about this? And all of a sudden it becomes a political discussion. It's not political. Anybody entering the country by any means needs to be quarantined for 14 days. We don't need to get another variant into this country, and we need to slow down the spread of the variants that we have, and you do that by eliminating dangerous variants entering our society. Now, the United States also needs to have a universal, comprehensive public health care system. The VA is the largest healthcare system in the United States and may serve as a future infrastructure. Its fourth mission is to aid the country in healthcare emergencies, including pandemics. During the COVID-19 pandemic, the VA hospitalized 400 non-veterans at VA facilities and outsourced over 1,000 healthcare staff to community nursing homes and non-VA facilities. Acceptance will allow us to change the way we live for a better normal and prepare for the next pandemic. Specifically, we need to upgrade and enforce standards for indoor ventilation and quality, build a better supply chain for tests and testing supplies, and this includes PPE, N95 masks, testing supplies, treatment capabilities, and we need to have manufacturing capabilities in the United States, and other countries need to have their own manufacturing capabilities. We need to maintain adequate stockpile of supplies, including therapeutics, tests, and PPE, and we also need to have a robust system of testing and reporting for dangerous pathogens, including genomic sequence testing, which is the utmost importance to track viral variants. Right now, we are flying blind regarding the spread of viral variants, a very dangerous situation. We are depending upon data from other countries, such as Canada, the United Kingdom, and Israel. Acceptance also means we need to have a paradigm shift in our thinking regarding indoor respiratory pathogens. paying as much attention to the enactment of strategies for their prevention as we do for pathogens spread by water and surfaces. In conclusion, what separates mankind from the rest of the biosphere is our intelligence and ability to leverage science. If we do not do this, we are in no better position than a tadpole. Unfortunately, almost all of our leaders appear to be hoping the virus will miraculously disappear. This did not happen last year, and it will not work in 2021. As an old Chinese proverb states, if we do not change our direction, we are likely to end up where we are headed. So it is of utmost importance that we prepare for the next pandemic. And unfortunately, we also need to prepare for the next surge of SARS-CoV-2. Thank you.